All right, as folks are logging into another Department of Medicine grand rounds, I just want to remind everybody that you can feel free to put your questions in the question and answer box or in the chat, which I will monitor for Dr. Moorman as he gives his presentation. So with that, I'm very excited to introduce our very own Dr. Moorman, who initially received his MD from Northwestern, but then joined us here at the University of Washington for his internal medicine residency and cardiology fellowship, where we were fortunate enough for him to stay on with us. And he's now currently a clinical associate professor of medicine in our division of cardiology and section head for general cardiology, as well as associate echo lab director for UW's Eastside Specialty Center. And in addition to all of that, he also is a principal investigator for the ischemia and ischemia CKD trials of ischemic heart disease management, which we are so excited to learn more about from you today. So I will hand over the podium and let you get started.
Great. Thank you, Alana. Thanks for having me. I was also a UW undergraduate, so you'll see my background there. I'm a little bit disappointed that the Husky game was canceled tomorrow, but hopefully they'll eventually play football. But we're here to talk about the ischemia trials. I'll start by saying I don't have any disclosures to report. And just an outline of what I'll be talking to you about today. We'll start with the background, looking at the landmark trials and the management of stable ischemic heart disease. And I'll present for you a case why there was Equipoise justifying conducting the ischemia in the ischemia CKD clinical trials. And then we'll jump into the trials, review the rationale and design for those trials, the results, and also discuss the limitations. And then lastly, have a discussion about where we might go from here and how these trials might or might not have changed our management for these patients. Now, before we jump into the data and I take you on a tour through these clinical trials, I'd like to just start with a case, a patient for you to think about as you're listening to this lecture. This is a real patient from my practice who I've seen within the past month. This is a 64-year-old gentleman with a history of type 2 diabetes and hyperlipidemia. And he presented to see me with about 8 weeks of exertional chest pressure with light to moderate activities. He first noticed it on a recent golf trip with his nephew. He could not even complete 9 holes of golf carrying his golf bag. And now he's having some chest discomfort when he climbs stairs, goes up hills, or takes his garbage cans out to the curb. He's not having any chest pain at rest. He's already on aspirin, simvastatin, and benazepril hydrochlorothiazide with controlled blood pressure. His exam's unremarkable. His EKG is normal. So I'd like you to think about, you can think to yourself, or maybe you can type an answer in the chat section if Alana wants to informally monitor these, but what would you do for this patient? Would you start this patient on anti-anginal medication and optimize their medical therapy for presumed coronary artery disease? Would you make medication adjustments and also get a stress test? Would you make medication adjustments and get a coronary CTA? Or would you make medication adjustments and obtain a coronary angiogram? And there's no right answer here, but I want you to think about those issues. Okay, so moving along to our first landmark clinical trial in the management of stable ischemic heart disease. I think this is the most well-known trial in this space before we had the ischemia trial. And recall, COURAGE was a trial that randomized patients from the cath lab who had proven coronary artery disease and had some clinical evidence of ischemia. And they were randomized to an initial strategy of optimal medical therapy with deferred coronary revascularization or upfront PCI. And you'll see here on the left that they screened over 35,000 patients and excluded the majority. The yield was very low in this trial. And you'll see some of the reasons. There were patients who were felt to have inadequate coronary anatomy for revascularization, or patients who were felt to have too severe angina that you couldn't treat them with medical therapy alone. But in the end, the COURAGE trial randomized a little over 1,000 people to each arm. The PCI arm, it's important to remember that for that era, we did not have drug-eluting stents. So patients were randomized to bare metal stents or optimal medical therapy. And over the course of this trial, PCI did not reduce the risk of death, MI, or any other major adverse cardiac event over the course. There was an early quality of life advantage for PCI, but that disappeared by 3 years. So this was a foundational trial that really proved that for stable ischemic heart disease, medical therapy seemed safe, and there was no advantage to early revascularization in terms of survival. A similar trial was done in the diabetic population. This is the BARI 2D trial, which randomized over 2,000 patients with diabetes and proven coronary disease on an angiogram to receive early or prompt upfront revascularization versus optimal medical therapy. Now, these patients could receive stents or bypass surgery depending on what the managing physician felt was most appropriate, and the patients were randomized in strata, so you had equal groups. You had randomization of patients receiving PCI and randomization of patients receiving CABG. And it's important to note that there was significant crossover from the medical therapy group over the 5-year follow-up. But again, this trial showed that there was no difference in survival or cardiovascular events between a strategy of optimal medical management alone versus optimal medical management and revascularization. Subsequently, a few years later, the FAME-2 study was done. This randomized patients from the cath lab who had a proven coronary stenosis, which was also shown to be functionally significant using a pressure wire. So this is FFR-guided PCI. Fractional flow reserve involves measuring the pressure drop across a stenosis. So it's a way to prove that the stenosis that you're visually seeing is functionally significant. Now, this trial randomized with the primary outcome of death, non-fatal MI, or urgent revascularization as a composite. And the trial was stopped early because there was a significant reduction in that primary endpoint. But it's important to note that that reduction was driven entirely by a reduced need for subsequent urgent revascularization. So in other words, patients who received FFR-guided PCI up front were less likely to be treated with PCI later, but there was no reduction in death or myocardial infarctions. They also did, in my opinion, an odd thing. They did a landmark analysis where they basically ignored the first 7 days. They censored the first 7 days after PCI, so that would exclude all the peri-procedural myocardial infarctions that can happen. There's a few other limitations with this study. And one is that urgent revascularization is considered a softer endpoint. It's not as clinically meaningful as a myocardial infarction or death. And there's concerns about bias when you introduce things like unstable angina or urgent revascularization into trial design. And one way to think about that is that in this trial, if a patient was randomized to optimal medical therapy and then they presented later to see a physician or went to the emergency room reporting chest pain, both the patient and the treating physician would be more likely to attribute that chest pain to, quote, untreated coronary disease. So that will bias the way that you adjudicate events. Whereas if a patient who received PCI follows up with chest pain, their chest pain might be more likely to be attributed to, quote, non-cardiac chest pain. So you can see how this introduces bias when you have softer endpoints. And I bring that up because that's something that we'll talk about more when we get to the ischemia trials. Now, when you do a meta-analysis of the stable ischemic heart disease trials that preceded the ischemia trials, you will see that there is no significant reduction in death, non-fatal myocardial infarction, unplanned revascularization, or even angina. So when you pull all the data from these trials, there's really no proof that PCI in stable ischemic heart disease patients reduces these events. Subsequent to that meta-analysis, a group in England did a very interesting study, the ORBITA trial, which you may already be familiar with, but this is the only blinded placebo-controlled trial of PCI. So what they did is they randomized patients with single vessel coronary disease to PCI versus a sham procedure where they had coronary angiography and FFR measurements, but did not actually undergo a percutaneous coronary intervention. and they randomized about 100 patients to each arm. And before randomization, they optimized medical therapy, and they did baseline assessment of exercise time and validated instruments of angina severity, the Seattle Angina Questionnaire, which was developed by John Spertus's group, who's a former cardiology fellow at the University of Washington. And then after these interventions, the PCI or the sham procedure, they repeated these measurements. And what they showed was that over time, both groups actually improved, but there was no between group difference. The patients who received PCI did not have a significantly longer exercise time or better angina score than the patients who received the sham procedure. Now, this study was debated and critiqued, and some of the limitations are that it was very small and that it was restricted to single vessel coronary disease. So may not be generalizable to patients with more diffuse or advanced coronary disease. Now, some of the counter arguments to the randomized data that I've shown you comes from observational data. And this figure here comes from a study that is often cited by interventional cardiologists and people in the cardiology community. But this was a single center study from Cedars-Sinai where they looked at over 10,000 patients from their nuclear lab. And what they showed, circled there in the red, is that if a patient had greater than 10% ischemia on a myocardial perfusion scan, the patients who were treated with medical therapy had a higher death rate compared to the patients that received a revascularization with a stent or bypass. Now, of course, there's major limitations to a study like this. This is observational data, and you'll see it's very unbalanced. You have almost 10,000 patients with medical therapy, and you're comparing them to 671 patients who were revascularized. But nevertheless, you would hear in the cardiology community, cardiologists talk about the ischemia burden and this belief that if a patient had high ischemia on a stress test, they would have more of a benefit from coronary revascularization. To counter that data, there's long-term follow-up data from the COURAGE trial, the trial that we began with. That first slide I showed you, they did a long-term analysis of the patients in COURAGE with a median follow-up of almost 8 years. And they looked at the patients within the COURAGE trial who had a myocardial perfusion scan at baseline to quantify their ischemia. And they just stratified these patient groups you'll see in this survival curve. They stratified them by mild ischemia treated with optimal medical therapy, mild ischemia treated with PCI, and then severe ischemia treated with medical therapy or PCI. And you'll see that these curves are superimposable. There was no survival advantage to PCI in any of these patient groups, and the ischemia burden on the baseline stress test did not predict survival. Now here's some quote real world data from Ontario, Canada. So they did a study where they looked at every patient in the province of Ontario who had a coronary angiogram, and then they propensity matched. So they did the best they could to get matched patients with otherwise similar characteristics. And they compared survival and myocardial infarction rates between the patients who were revascularized and the patients who were treated with optimal medical therapy only. And they showed in this study a statistically significant about 25% risk reduction of death and myocardial infarction if you were revascularized. But again, this is observational data with all of the limitations that go with that. Should also be noted that about 10% of the patients here had left main coronary disease, where we don't think that there's any equipoise there. We know that CABG offers a survival benefit. So all the other trials I've shown you and ischemia trials also exclude patients with left main coronary disease for that reason. So I hope that I've shown you that there was equipoise before ischemia. You had things on the left favoring a coronary revascularization strategy. And then you also had the findings on the right favoring a conservative approach. So this was the justification for performing the ischemia trial. So the ischemia hypothesis was that an invasive approach of routine early cardiac cath with intent for optimal revascularization in addition to optimal medical therapy would reduce the incidence of major adverse cardiac events over an average of about 4 years, as opposed to treating patients with optimal medical therapy alone. And this is how the study was designed. So you start with a stable patient. I want to remind everybody we're talking about stable ischemic heart disease now, so not acute coronary syndromes, but a stable patient with moderate or severe ischemia on a stress test. And the ischemia burden was verified by a core lab. So the stress tests, of course, are performed at the participating trial sites, and this was an international clinical trial. And then a core lab validated that there was moderate or severe ischemia. If a patient had moderate or severe ischemia, they would then receive a blinded coronary CT angiogram. And the purpose of that was to screen fail people who either had left main coronary disease, where it would not be appropriate to randomize them, or patients who didn't have significant coronary disease and had a false positive stress test. Now, if patients had chronic kidney disease with a GFR between 30 and 60, they could be exempt from the coronary CTA in order to spare them the contrast, as long as the local provider felt like that they were not at risk of having left main disease. So again, screen fail for left main coronary disease. If not, then you'd be randomized to strategy there on the left, invasive strategy with cath within 30 days and intent to revascularize in addition to optimal medical therapy, versus a conservative strategy, which is to start with medical therapy alone and reserve a cath for an event, something like an acute coronary syndrome or escalating angina that could not be controlled with medical therapy. Now, the primary endpoint in the ischemia study was a composite of time to cardiovascular death, myocardial infarction, or hospitalization for unstable angina, heart failure, or a cardiac arrest. And one of the criticisms or the commentary surrounding this trial was that the endpoint was broadened after the trial began enrollment because event rates were lower than expected. Now, I want to point out that that was a pre-specified contingency. The original primary endpoint was to look at only the hard endpoints of cardiovascular death or MI, but the trial leadership pre-specified that they would broaden the endpoint if necessary due to low enrollment or low event rate or both. And then the secondary endpoints were just the components of the primary endpoint and all-cause death. Now here's the eligibility criteria. This is a pretty typical trial for stable ischemic heart disease, and that we're looking at adults. You had to have moderate or severe ischemia on the stress test, and I show you there how that's defined, but that's more 10% or more ischemia on a perfusion scan, or 3 or more inducible wall motion abnormalities on an echocardiogram or a stress MRI. This trial also allowed people to be enrolled with an abnormal exercise treadmill test alone without cardiac imaging. And that was because globally, not all countries use as much stress imaging as we do in the United States. And about 25% of the patients who were enrolled in ischemia had just a plain Bruce treadmill without imaging. Now the trial, it's important to remember, we excluded people who had severe heart failure or who already had unacceptable angina despite optimal medical therapy, patients who'd had a recent acute coronary syndrome or who had recent revascularization within the past year. If a patient had a GFR less than 30, they could be enrolled in the ischemia CKD ancillary study, which we'll talk about later. Now, I want to point out that this trial was actually very hard to randomize patients in, and there was a few reasons for that. One was a term that David Marin at Stanford, who's on the one of the main PIs for the trial, talked about intellectual versus visceral equipoise. people in the cardiology community, we know the literature, and most cardiologists would tell you that they understand all the preceding trials, but that when it came down to kind of putting their money where their mouth was, so to speak, or randomizing their own patients, they had a hard time doing it. They would say things like, I support the trial, but not my patient, or, wow, I would randomize this, but it really looks like the LAD is involved. So a lot of people just didn't feel comfortable randomizing their patients. Their gut wasn't really telling them that there was equipoise to justify this trial. And on the other hand, on the other side, patients were not ambivalent about this. Typically, patients have their own ideas, and it's hard to be ambivalent about being randomized to medical therapy versus an invasive intervention. And for patients, it makes sense to a layperson that it would be better to open my arteries. Why wouldn't you do that? So it really takes a long discussion and consent process to talk to patients about that. And part of that's our own doing. We as cardiologists and people in the medicine community, when we talk to patients about their coronary arteries, we tend to use poor analogies, like plumbing analogies. And we talk about sending people to the cath lab to, quote, fix their arteries, even though this is a diffuse biologic disease that really needs to be treated with medications. We focus on the mechanical interventions. And that was shown in a study where even after COURAGE was published, 88% of patients surveyed in a cath lab felt like the stent that they received was going to prevent an MI and, quote, save their life. So in the end, I was able to enroll 13 patients at the University of Washington, and it took a lot of work. And this was my first experience with a randomized clinical trial. And randomized trials are all about enrollment. So I encourage everybody listening today that if your colleagues are conducting trials, please help them find patients, because it's really important to the care we deliver. Okay, so study flow, just walk you through what happened. So over 8,000 patients were initially enrolled, but there was over 3,000 screen failures, either insufficient ischemia according to the core lab, or no obstructive coronary disease on the CCTA, or the discovery that patients actually did have unprotected left main disease and so should have bypass and not be randomized in this trial. I'm not going to talk about the Chow study today. That's an ancillary study. We just don't have time to review it. So over 5,000 patients were randomized, and about 75% of those patients did get the blinded coronary CTA. Recall that if patients had a low GFR, they didn't necessarily have to have that. And so you had about 25 or 2,600 patients randomized to each arm with a median follow-up of about 3 years. And almost everybody completed follow-up. So there was very good retention of patients and follow-up of data. And these are some selected baseline characteristics. You see that average age was about 64. A little over 20% of the participants were women. Most of the patients had hypertension. Almost half had diabetes, and about 20% a prior myocardial infarction. The average ejection fraction was very normal. And most of the patients had a history of angina, about 90%, and about a third of the patients reported that their angina had worsened over the preceding 3 months. But I'll show you data later in the talk that the angina burden in this trial was actually relatively low when you look at measuring actual angina scores. Now, when you look at the baseline coronary anatomy of who was enrolled in the study, you'll see that there's a pretty good distribution of single, double, and 3-vessel disease. And when you look at the specific arteries involved, there's a good distribution, and the majority of the patients had involvement of the LAD. The one patient there who was randomized who had left main disease, they'd had a prior CABG, so they were eligible for the trial because it wasn't unprotected left main. So important to know, this study had a good distribution and included patients with multi-vessel disease in addition to moderate to severe ischemia on their stress test. So definitely a high-risk population. These slides just show that medical therapy optimization was good and it improved over the course of the trial. The yellow bars are the rates of medication use at baseline, and the purple bars are the rates of use at study completion. And on the right-hand side, you'll see the specific targets that the trial was aiming for, with an LDL goal of less than 70, systolic blood pressure of less than 140, being on aspirin, not smoking. And if you met all those criteria, you were considered to have a high level of medical therapy optimization. And you see there that even within a clinical trial, we can only get about 40% of people up to what is considered optimal medical therapy. So in the real world, that's going to be much lower. There's still a big opportunity for improvement there. And this just shows the catheterization and revascularization rates. So of course, in the invasive arm, almost everybody had their cardiac cath performed. In the conservative arm, the blue, over time, you had some patients who were crossing over and getting angiograms later. And similarly with revascularization, most of the patients in the invasive arm of the study were revascularized early. Some were not because they didn't have anatomy that was amenable to coronary revascularization. But again, you did have crossover. You had patients in the conservative optimal medical therapy arm who did have coronary revascularization over time. Now, this just shows you the procedures that the patients received. So if you look at the first procedure for those revascularized in the invasive group, which was about 80%, you'll see that 3/4 of the patients had PCI, and almost everybody had a drug-eluting stent who had PCI. And about 25% of the patients had a CABG, and almost everybody had an arterial graft, which is expected. You really want to use the Lima graft, the left internal mammary artery, when you do a bypass surgery, because that's what provides the advantage over stenting for the left main. And the trial had a very strict protocol that called for complete revascularization. So really the goal was to revascularize as best as possible. Now, of the 20% in the invasive group who did not receive revascularization, it was actually because about 2/3 of the time they ended up having insignificant disease on their angiogram. So their stress test maybe reflected microvascular angina or just a false positive study, and the CCTA was not accurate. But then about 1/3 of the time, these patients had such bad coronary disease that it couldn't be revascularized. And this shows us what the primary outcome for the two strategies. So the conservative in blue and the invasive in red. And there was no significant reduction in the composite outcome of cardiovascular death, MI, or hospitalization for unstable angina, heart failure, or resuscitated cardiac arrest. What you'll note here is these Kaplan-Meier curves, they cross. And this is interesting because the Cox proportional hazards model assumes that the hazards happen at some rate, but they're proportional. And when a Kaplan-Meier curve crosses, you violate that assumption, and you have to do different statistics to analyze your data. And I am not a statistician. There might be people in the audience today who understand this much better than me, but it is important to understand that that is a potential limitation, or at least something to think about when you're reviewing trial data. So when you look at the absolute difference early, there was a hazard associated with the invasive approach. And that makes sense because patients undergoing invasive procedures have a risk for peri-procedural complications like peri-procedural MI. But later on, the curves crossed, and you might see later that there's an advantage to the invasive strategy. And what they did in the manuscript to address this better is they actually, they present you in a tabulated form the event rates for every 6 months, or for 6 months and then every year increment. And what it shows here is that there's a hazard associated early, but later there may be a benefit. Nevertheless, when you look at the entirety of the data, there's no significant reduction in the primary endpoint with the invasive strategy. Now, when you look at the secondary outcome of cardiovascular death or MI, so remember this was the original primary endpoint, this removes those softer endpoints, you get very similar shaped curves. I'll just cruise through that. And again, they show you in the manuscript, they tabulate the data if you want to look at that more closely. When you look at cardiovascular death, there is also no reduction, no advantage to the invasive approach. And all-cause death, there's no reduction. Now, one of the interesting things that comes out of this study is that when you look at myocardial infarction, it has that similar shaped curve where there's an early hazard with the invasive in red, and then maybe a later benefit. And why is that? Well, of course, if you look in the upper right, there's more peri-procedural myocardial infarctions when you have a procedure. So that's the early upfront risk to having coronary revascularization, that you could have a peri-procedural myocardial infarction as a complication. Now, what's interesting in the lower right here is spontaneous myocardial infarction. We do not think of revascularization procedures as reducing the risk of spontaneous MI. That's what we think the medication is doing. And in fact, that probably is what's happening here, is the patients who were revascularized had lower rates of spontaneous MI, probably not because of the stent, but because of the associated dual antiplatelet therapy. We know that patients who are on dual antiplatelet therapy have lower risk of spontaneous MI than patients on aspirin alone. So that's probably what we're seeing here. Now, when you look at pre-specified subgroups to see if any subgroup of patient did have a differential benefit to the invasive approach, there was not. So it didn't matter how much ischemia the patient had. It didn't matter whether or not they had diabetes or how frequent their angina was. So there was no suggestion of any subgroup that would have a differential benefit to an invasive approach. So in conclusion, the ischemia main trial showed that an early invasive approach in addition to optimal medical therapy did not significantly reduce the risk of major adverse cardiovascular events, cardiovascular death, or all-cause death. Now, what about symptoms? It's important as physicians and healthcare providers, we are not only treating patients to reduce their risk of mortality, we also treat patients to make them feel better. So the study did show that an early invasive approach was associated with better angina control if the patients had at least monthly angina at baseline. Now, if you look up here in this table, the baseline Seattle Angina Questionnaire summary score was in the 70s in both groups. And that equates to roughly Canadian Cardiovascular Society Class 1 angina, which is pretty mild. That's just angina with moderate to strenuous activities. So this was not a highly symptomatic population. What you see in this density graph is that the Seattle Angina Questionnaire score improved more. It shifted to the right more if a patient was treated with an invasive approach, which is also broken down in the lower figure. So the study does seem to show that patients treated with an early invasive strategy had better angina control. Now moving on to the ischemia CKD study, which is the ancillary study for the patients with low GFR or on dialysis. This was a very important study because CKD is underrepresented in the preceding clinical trials of stable ischemic heart disease, and they are our higher risk actually our highest risk patients. Patients on dialysis or with advanced CKD have a very high risk of cardiovascular death. They're more likely to die of cardiovascular death than they are to get a kidney transplant or to go on to dialysis. So when you look at BARI 2D, that early study of diabetics that I showed you, they excluded patients with a creatinine greater than 2. And the COURAGE study only enrolled 16 patients total who had a GFR less than 30. So we really had a paucity of data for how to treat our patients with ischemic heart disease and chronic kidney disease. So the CKD study randomized 777 patients who had moderate to severe ischemia on their stress test and had a GFR less than 30 or were on dialysis. And because of their poor kidney function, there was no CCTA done in this study. So the patients were not randomized if their physician felt like that their stress test looked like they could have left main disease. If you look at the characteristics here, similar age to our previous study, a few more women, almost everybody had hypertension, over half had diabetes, about half was on dialysis. So this is a very high risk group. Now, when you look at what was found on the coronary angiograms for the patients in the invasive group, it's interesting. Actually, 26% of the patients randomized the invasive group actually did not have any flow-limiting epicardial coronary disease. So they had stenoses that were less than 50%. And the reason that could be is some of these patients likely have true positive stress tests, but it's due to microvascular disease, not epicardial disease. But then there would also be patients who were enrolled who had false positive stress tests who just didn't have coronary disease. When you look at the remaining patients who did have some degree of coronary stenosis, there was an equal distribution of single, double, and 3-vessel disease. And then we found 2 patients who actually did end up having left main disease. Now, there was no reduction in the primary endpoint of death or MI. And there was no difference in the major secondary endpoint, which was the same composite endpoint used in the main trial. So absolutely no difference in these composite endpoints. Now, when you look at the safety endpoints, the patients treated with the invasive approach were more likely to go on to dialysis. And of course, that makes sense. Despite the best protocols with contrast sparing, the patients who received an angiogram, that was a risk for progressing kidney disease and going on to dialysis. Now, moving on, I'm going to talk a little bit about some of the limitations or questions with these studies. The first of which is the ischemia trial underpowered? So the original trial anticipated randomizing 8,000 people. We only ended up randomizing a little over 5,000. The original trial design also anticipated a 20% event rate in the conservative therapy arm, but the event rate was lower than anticipated. And we always see this in our cardiovascular trials. The event rates over time are coming down because medical therapy over time is getting better and better. And we're always kind of chasing that. And as trials are designed, they're always lagging a bit. So the event rate in the conservative therapy arm was lower. And that's, again, the lower event rate and the lower randomization rates are why that composite endpoint was broadened. But what this comes down to is that when the trial was designed, it was powered to have an 80% power to detect a 15% difference in the primary outcome. But really, at the conclusion of the study, there was really only about a 65 or 70% power to detect that degree of change. So there is some risk of type 2 error here. One of the other questions with this study is, how do we think about peri-procedural MIs as compared to spontaneous MIs? In the trial, biomarkers, troponin, CKMB, they were tested in everybody who received a coronary intervention. We don't do that in routine clinical practice. We don't check cardiac enzymes after an elective PCI. Surgeons do not routinely check cardiac enzymes after they do a bypass surgery. These are just things that are done within the confines of a trial. Now, peri-procedural MIs are associated with mortality in several studies, but not all. And it also depends on how you define it, what your threshold is for calling something a peri-procedural MI. Because of course, it's expected that you will have some troponin and CKMB elevation after a balloon has been inflated in a coronary artery or after a surgeon has performed a bypass surgery. Ischemia did use the most stringent or highest threshold to call something an MI, but that's something to think about. Is a peri-procedural MI the same risk as a spontaneous MI? Are they equatable? And then I talked earlier about this. If a coronary revascularization procedure reduced spontaneous MI, how did it do that? And I think it's probably the DAPT. It's not the stent. And we all should understand in this audience that spontaneous MIs are due to plaque rupture. And you'll see the treatment targets listed there at the bottom. But these are the things we can do with lifestyle interventions and medical therapies to reduce risk of a plaque rupture, MI, or coronary syndrome. Stents do not prevent this. Medications do. So to summarize, ischemia strengths, it's the largest study that's ever been done in stable ischemic heart disease. It's about twice as large as COURAGE. This study did study patients with a high ischemia burden, which was confirmed by the core lab. One of the criticisms of the COURAGE trial was that maybe those patients didn't actually have much ischemia, so this trial addressed that. These patients were on contemporary medical therapy. There was excellent retention of patients within the trial. There was very careful quality of life assessment, and the events were adjudicated with very rigorous standards. But there are limitations, which we just reviewed: the lower event rates and enrollment rates, the addition of softer endpoints to that primary outcome, and the fact that this study is not generalizable to all our patients with stable ischemic heart disease, such as patients with reduced ejection fraction. We also wonder, what would this trial have shown if follow-up was longer, if there was funding and time available to follow these patients longer? Now, when this study was published, you can imagine that a lot of my colleagues, particularly those that work in the cath labs, had some concerns about this study, or criticisms. And there was also a lot of people saying, well, we already knew this. Why did we do this study? What a waste of money. What a waste of resources. The previous trials already showed the same thing. Well, if we already knew this, why weren't we doing this in practice? And this was a study from JAMA in 2011 that looked at patients in the National Cardiovascular Database Registry, looked at almost 500,000 people undergoing elective percutaneous coronary interventions. About a third of the patients received their intervention before COURAGE was published. 2/3 received it after the COURAGE study was published. And you just see here that the rate of optimal medical therapy use before PCI is low. Less than 50% of patients are on what's considered optimal medical therapy before they received a PCI. And even after, medications are not being optimized to the same degree. So hopefully the ischemia trial further reinforces the importance of optimizing medical therapy, and we can get better at that. Another criticism was that the trial was too expensive. Should it have been done? It was a roughly $100 million trial. Was it worth it? Well, what these figures show are what angioplasty and bypass surgery cost in the United States, red, relative to the rest of the world. And not surprisingly and sadly, we are the leader in in terms of cost or expense of performing these interventions. And if you look in the United States only, there's almost 1 million PCIs per year for elective, there's almost 1 million PCIs total, and about 1/3 of those are for elective indications like stable angina. So if you do 300,000 PCIs times $32,000 per PCI, we are spending almost $10 billion annually on percutaneous coronary intervention. So in that context, I do not think a $100 million trial is expensive, especially if it influences how we treat our patients and how we use our resources. So where do we go from here? I would argue that the ischemia burden on a stress test really doesn't matter. And I think we should start to think about whether a coronary CTA might actually be the better first-line test for our patients presenting with stable chest pain. And the advantages are that a coronary CTA will identify any degree of coronary disease. So even if your patient has mild coronary disease that's not flow limiting and may not be the cause of their chest pain, they should still be on optimal medical therapy. A CCTA can also identify left main coronary disease where a patient should be referred for bypass surgery. And in fact, the Scott Hart trial was published a couple of years ago in the New England Journal, and this study looked at the use of CCTA as the initial strategy or test versus a conventional approach of stress testing. And it showed that for the patients in the CCTA group, there was a reduced risk of death and myocardial infarction versus the usual care approach. And that is because probably that patients were getting started on optimal medical therapy. Remember, a stress test would only be abnormal if somebody has flow limiting coronary disease, but even if they have mild coronary disease, you would want them to be on medical therapy. And in fact, the European Society of Cardiology and the National Institute for Health and Care Excellence in the United Kingdom, they now recommend CCTA as the first line testing for patients with stable chest pain. So we are waiting here to see if the United States guidelines will follow, because until we have more guideline support and clinical trial data, insurance payers do not always pay for this test. So here would be my proposed approach to a patient who you are suspicious might have coronary disease. And that would be that if you have a stable patient with chest pain and they have preserved ejection fraction, or at least greater than 35%, that you ought to think about starting with a coronary CTA, or perhaps even a cath if your suspicion is high. If you find left main disease, they should be started on medical therapy and referred for a bypass surgery. If they don't have any coronary disease, then you don't have to treat them with medications for coronary disease. You might identify patients who don't need those medications, spare them the medication. But if you find coronary disease without left main, you should do a trial of optimal medical therapy and then consider revascularization if your patient continues to have unacceptable angina. Sorry, my slides just stuck here for a second. Here we go. So here's the case conclusion to the case that I presented before we got started. This patient had such a high pretest probability for coronary disease based on the Diamond and Forrester classification of typical angina in a 65-year-old male that I actually elected to just go straight to coronary angiogram. I started on optimal medical therapy first, and his symptoms actually improved quite a bit with the addition of a beta blocker and a nitrate. But what you'll see I found there was distal, tight, left main coronary disease, and he's been referred for bypass surgery. So what are the take-home messages here? Medical therapy works and is a safe first-line approach for your stable patient with chest pain and an abnormal stress test. Revascularization is still useful. I do think it is better at angina relief, although it is interesting to think about the ORBITA study and maybe some of the benefit to angina relief is the placebo effect of having an intervention, but all of the randomized trials have been pretty consistent that revascularization is better at angina relief than medical therapy alone. Recall ischemia, when you're thinking about patients, these trials do not apply to patients with left main disease or acute coronary syndromes, unstable angina, or heart failure with reduced ejection fraction. It's interesting to think about, does revascularization really reduce spontaneous MI? And I think it's probably not the procedure, but the dual antiplatelet therapy that comes with it. And lastly, coronary CTA may be the better first-line test for our patients with chest pain, but we will need more studies on this, looking at outcomes and resource utilization before that becomes standard of care. And I'd just like to thank everybody that was involved in this trial. We have a clinical trials unit, and the coordinators and the manager and the director do a ton of work. Bryn Smith is now a medical student here. I don't know if she happens to be listening today. And then I had co-investigators within my division, but also Bilal Malik in nephrology. And I want to thank the UW kidney transplant team who allowed me to randomize some of their patients in the CKD study. And with that, I'll end, and I'm happy to take questions.
Thank you so much for such a great overview of a really large and comprehensive amount of data. So there are a number of questions. First, kind of to one of your take-home points about coronary CTAs, there's a question of, is there a role, do you feel there's a role for coronary CTAs in asymptomatic patients who have high-risk features, like, for example, family history, not necessarily those presenting with chest pain?
Yeah, for a patient who's not presenting with chest pain, I would not start with a coronary CTA, but I would consider, and I don't make this distinction, you might consider a coronary calcium score, and those are two different tests. So coronary calcium score is a non-contrast CT scan that just measures and quantifies the calcification in the coronary arteries. And there's a lot of data that validates using that as a way to further refine your risk assessment on top of using traditional risk factors. So using something like a coronary calcium score in an asymptomatic patient may help you decide, for example, whether to start statin therapy in somebody. So, and the best way to use that is probably intermediate risk patients where the coronary calcium score would influence you one way or another in a treatment decision. But yeah, a coronary CTA, so using contrast to actually look at the coronaries, is it should be reserved for patients with stable chest pain for the purposes I talked about today. But there's also research that has looked at its use in emergency departments as a way to assess people presenting to ERs with chest pain.
And I think there's another question that kind of dovetails into that is there a place for coronary calcium scoring in the evaluation of stable ischemic heart disease? And if so, where would that fit in all of this?
Yeah, we don't use coronary calcium scores in people once we've already established a diagnosis of coronary disease. Once you know somebody has any form of atherosclerosis, they really should be on aspirin and statin therapy and blood pressure control, et cetera. So a coronary calcium score is really a screening test for kind of borderline or intermediate risk people when you're talking to them about primary prevention and whether or not to start. It's usually a statin that you're really talking about.
Those are great points, and oftentimes folks can get bogged down in all of the new testing and what to choose for which patient. So it's a really helpful overview to have. There's another question that's a little different. About earlier on, you mentioned with some of the struggles of recruiting and enrollment for the ischemia trial, particularly with the visceral equipoise that folks had. Do you have any sense on a way to overcome this? Because this is likely to be a problem moving forward as our event numbers go down and people are invested in their patients. So any thoughts on that?
Yeah, boy, it was a real tough problem because I had colleagues who I thought, just knowing them and how they practice medicine, that they would have been very happy to enroll a patient, but they just ultimately didn't always feel comfortable. I don't know. And the hard thing with clinical trials, I think a lot of people are starting to wonder, is the traditional large kind of late breaker clinical trial, are they even feasible anymore? As event rates are getting lower and trial expenses are getting higher and higher, I'm told by some of my older colleagues and experienced clinical trialists that it's just really getting a lot harder to conduct these mega trials. And I think that groups are going to have to get more creative in how trials are designed. And I don't know what the solution is really to overcome that visceral equipoise or gut feeling when people are just not comfortable randomizing their patient. Of course, we always try and give them more knowledge and explain all the background, but as we know, with our colleagues and with our patients, knowledge alone isn't always enough to sway opinion.
Yeah, I think that's a really great point, and a really great point about the future of these large clinical trials in general, I think is might be changing. So that's an excellent point. There's another comment or question from the group of, do you ever think that the Bruce exercise treadmill test will go away? And if not, what is the role for that test in the era of our advanced imaging like coronary CTAs and calcium scoring?
Yeah, so I don't know. I don't think that traditional exercise testing will ever completely go away because there's many valid reasons to assess somebody's exercise capacity in the lab, and you get a lot of prognostic information from somebody's exercise time. We sometimes use it to risk stratify people who we know have coronary disease, but we want to get an understanding of, how bad is their angina, like how much does it take for it to come on, et cetera. So no, there will always be a place for exercise testing. The way we would position exercise testing with or without cardiac imaging, though, might change. And what's interesting is what they recommend now with the NICE guidelines in the UK is you actually start with the CCTA. And if the CCTA is indeterminate, because sometimes these coronary CTAs, they're not perfect. If the CCTA is indeterminate, then you do the stress test to get a sense if there's ischemia in that distribution. Now, Catherine Otto pointed out to me once, she knew Robert Bruce. Of course, he was the chief of cardiology here at the University of Washington. He was interested in exercise testing because it wasn't feasible to do cardiac imaging in his era. You couldn't, it wasn't practical to screen patients with coronary angiography. So now that we have a CT scan that with very good but not perfect accuracy can assess the coronary arteries, it's a more direct way to look at the coronary arteries and assess somebody's risk.
Great. I think that's a great point, and we're always learning how to incorporate new and old testing into our care for patients. So again, I want to thank you so much for such a great and comprehensive talk. Definitely folks in the chat and on the questions are appreciating all of the great information you shared. So really appreciate having you here with us to present. And thank you for your time. Yeah. And thank you for all those who attended. Next week, we are going to have Dr. Rashmi Sharma talking about addressing inequalities in care for patients with limited English proficiency. So a topic that's pertinent for all of us. So one more thank you to Dr. Moorman, and thank you all for those attending, and we'll hopefully see you all next week.
All right. Thank you.